Okay, welcome, sir. To start with, మీ మెడికల్ ఆర్ సర్జరీ జర్నీ ఎలా స్టార్ట్ అయింది? ఎప్పుడు స్టార్ట్ అయింది? ఏంటి అనేది ఒకసారి మీరే చెప్తారా సార్ ఒకసారి?
థ్యాంక్స్ అండి. యాక్చువల్‌గా ఐ వాస్ రియల్లీ సర్ప్రైజ్డ్ టు గెట్ ఇన్విటేషన్ ఫ్రమ్ యూ ఫస్ట్. మెడిసిన్, సర్జరీ అన్నది యాక్చువల్‌గా టు బి ఫ్రాంక్ విత్ యూ, we have a big family. My father had 7 children and actually exactly the middle. The first brother, eldest brother, became an engineer. He was interested in mathematics. So obviously 60s, late 60స్‌లో ఏముండేది? ఇంజినీరింగ్, డాక్టర్, అప్పుడప్పుడు బ్యాంక్ ఉద్యోగాలు. ఈ మూడే ప్రాముఖ్యంగా ఉండేవి. మై ఫాదర్ ఇన్ హిస్ ఓన్ విజ్డమ్, వీ డోంట్ హ్యావ్ ఎనీ రిజర్వేషన్, యూ హ్యావ్ టు రీడ్ వెల్, దట్ ఈస్ ద ఓన్లీ సొల్యూషన్ ఫర్ యువర్ ప్రాస్పెరిటీ. అండ్ హీ సజెస్టెడ్ medicine. At that time, it was considered to be a very expensive affair. My father, of course, was a headmaster, so obviously finance background was not there. So he expressed desire the eldest son should become an engineer so that he can support other brothers. That was the main reason. And my brother was a good student. He managed to get 99 out of 100 in mathematics in PUC, pre-university course. At that time, no entrance examination based on the original marks. We got a seat in SP University, Tirupati. No problem. Then second and third brothers, so he expressed desire that one of them should become a doctor because the eldest one is able to support the medical field. So second brother was assigned to become a doctor. He was very good student, brilliant student, I should say. Unfortunately, he could not get into medicine. The next was third and fourth. So third brother was not interested in either medicine nor in engineering. So he wanted to become he just wanted to do some BA or BSc. And so next he told that, my father told me, why don't you become a doctor? So this is the background. Okay. Coincidentally, I think in 6th standard or 7th standard, my English teacher, Ranjan Beg, so he was asking us to frame sentences like neither nor, either or, like that. So I do not know what happened on that particular day. I gave an example for either or, saying that either my brother or I should become a doctor in your family. It was nearly spontaneous. It was not planned at all. So there was no plan to become a doctor even for me or not for him. Anyway, that happened in somewhere in mid 60s. That was, I think I was in 6th or 7th standard, I don't remember. But by the time I came to 10th class, my batch was the first SSC batch. So at that time, SLC, PUC, college. So my batch was the first secondary education. So when I came to 10th class, my brother was in 12th, the second brother I'm talking about. Unfortunately, I told you, he was a brilliant student. Unfortunately, he could not get into medicine because there is no entrance examination and admission was based purely on the marks which they obtained in the qualifying examination. In fact, he got more marks in other subjects rather than science. Anyway, he could not make it. My brother didn't want to pursue again, second time. So my father told, no harm. So whatever we want, surprisingly, after doing this 12th standard, instead of going for the science stream, he took MPC, Mathematics and Physics and Chemistry in BSc. And of course, I told you, he's a brilliant student. So subsequently, he joined BRCA, became a good scientific officer. Then in 12th, that is an intermediate. So obviously, my father already expressed, of course, he never forced us. You should remember that he never forced us to study. But he told in guidelines, we belong to forward caste. We don't have any landed property. If you have to live comfortably, you should have a good education. These are the only 3 things he used to tell. And you have to work hard, no alternative. So during intermediate, then of course, God has been very kind. So our batch was the first entrance examination to join medical college. Then God has been kind, and then I got into medicine. That's how I entered into medical college. Though I use the word thank God, by the God's grace, at that time I should mention I was not a believer of God, existence of God.
Okay.
I thought that, okay, because whatever the scientific knowledge was there, so I thought that God as such will not exist in this world. That was my concept. Anyway, I joined medical college in Kannur Medical College. When I started studying anatomy, physiology, biochemistry, I was fully convinced, you name it, as a God, but there is some supreme being to manufacture this a wonderful engine like human being, because it's not possible with scientific knowledge to create such a wonderful machine. So then I started believing in, I told you, it's very easy to convince ourselves to the existence of God. So, okay, if you don't, at least some supreme being is there, or some supernatural power is there, you name it anyway. So that person or creature or whatever you name it, he was or she was responsible to create such a marvelous machine. So now I can always say that, and it is very easy to say that, okay, God is there, so that God is running this show. So that is easier concept if you don't believe in a supreme being. So I started believing in so-called existence of God from anatomy, physiology, biochemistry years onwards. Then you asked me, how did you become a surgeon? When I reached final year, where I had to study medicine, surgery, gynecology, etc., believe it or not, my favorite subject was obstetrics, not gynecology. I thought that that's a wonderful subject. I think if you do service, I think you can do service for both mother and child. That was my concept.
Oh.
And I was really interested in obstetrics. Of course, I'm equally interested in medicine and surgery also. But when compared to these three subjects, gynecology I excluded, I already told you.
Oh.
So I'm talking about obstetrics, part of the gynecology and obstetrics. So when I finished my medicine, that is finally MBBS, I got good marks. In fact, I stood first in both medicine and surgery. And professor of medicine expected that I should follow him, and then I should choose a medicine as a specialty. And as usual, the surgeon, the head of the department, Ram Garu, he expressed that, no, you should become a surgeon, etc., etc. So during internship, I told you, my first interest was obstetrics. Then medicine and surgery, I was interested, but main object was to become an obstetrician rather than a gynecologist or a physician or a surgeon. But during my internship, my first posting in internship was in surgery, that too in neurosurgery, super special department. So when I assisted my first day itself, he was doing burhole, and the assistant professor knows that I stood first in surgery. Naturally, he expected that I should become a surgeon. Then he told me how to wash. I was wearing kashidar. I do not know whether you are aware of it or not. At the wrist, it's just like wristband. We used to have a kashidar. So he told that if you want to become a surgeon, no rings, no kashidaram. Are you happy? I told him, no problem, sir. This is because at that time somebody Shringeri Swami gave, that's why I'm wearing it. So I got it. Still, I got that kashidaram in my home. Then, of course, I took fancy for surgery. Then, over a period of next 3 months, I work in medicine department also by that time. I realized surgeon is nothing but a operating physician. That is my full concept even now also. If you want to become a good surgeon, you should have good thorough knowledge of medicine also. So surgery is actually a branch of medicine where the physician who is able to do surgery is considered as a surgeon. So basically he is a physician, but an operating person. That's why we call it surgery. So that's how I developed interest in surgery.
అప్పట్లో మీ రెసిడెన్సీ లైఫ్ ఎట్లా ఉండేది సార్?
I should say that nowadays residents are pampered.
Oh.
That is a basic concept all the old timers feel. I also subscribe that idea. I will tell you my residency in Chandigarh. I told you I did only 1 year residency because because of reservation problem, I could not pursue the second year onwards. Then I shifted to airports, etc. During my first year residency, the concept was clear. There is no doubt about it. If you are a first year resident, you should draw the blood sample. You should send the sample, either you take it or you take the help of others, it should reach the lab. Our resident, senior resident or assistant professor is interested in report. Whether you got it done on your own, whether you got it done through your assistants. Assistants means part sahayakas and helpers or relatives to the patients. It's immaterial for him. What he required is the report. Suppose the patient get admitted about 8 o'clock in the morning. Suppose surgery has to be done. Obviously, emergency surgery, we require the reports at the earliest. Obviously, it is your duty to make sure that reports are available when the patient is wheeled into the operation theatre. So there is no question of depending on others.
Yes.
If you are able to do it on your own. If you are able to take the help of somebody, take. It's not a concern of the assistant professor, senior resident. When the patient is being wheeled into the operation theatre, report should be available. Nowadays, of course, at that time there is no online system. We have to draw the sample. You should see that blood doesn't get clotted. If it gets clotted, again we have to repeat. So you know how to draw the sample. Everything we know.
Yes.
By the end of 3 months, we are well versed. And we already got adjusted to their new life. There is no question of postponing things. If the job has to be done, it has to be done. There is no excuse at all. If you're not able to sleep in the night because of emergency, that is none of the business of the senior resident. It is your duty to be physically active, mentally fit to assist him the next day morning. There is no question of day off. And at the end of 6 months, I realized that there is a good concept. Why I am telling you is, you saw the patient, you worked up the patient, and obviously you will be more interested to know what is going to happen in the operation theatre. If you feel that by 7:30 or 8 o'clock, your duty is over, you want to go and take rest, obviously the anesthetist may not be able to give anesthesia during your working period. Obviously, he will give anesthesia maybe after 8 o'clock. And if you want to go on day off, you will not be learning anything. You just did a donkey's work, and the fruit is consumed by the other resident. So that was my concept. So we never used to take day off. We used to work till 1 o'clock next day morning. Then 1 o'clock, the cases are over. We used to go and take rest for about rest that time. So that was it. Nowadays, the residents are more vocal. That's what I noticed. And they are not able to cope up with the work. And mind you, our working was hectic. In every day, on duty day, we used to get not less than 8 or 10 cases which required surgery. And almost equal number, maybe more, who required conservative management or further follow-up. Here, if the patient gets 2 cases who are worked up for surgery, they feel that they get exhausted. That is a basic difference nowadays, most of the residents. Another problem with the present day generation is the number of seats for residents was less during our days. There is no question of distributing the work. Now, the PGs, in my own it I saw, sir, this month I will look after male ward. One resident came and asked me. Other 2 residents, one fellow, he is giving me advice. I should not use the word advice, but he was giving suggestion. Sir, I will be looking after the only male ward. Next month I will see the female ward. Next month I will do the rest of the peripheries, etc. I looked at him, I told him, suppose you will not assist any female patient during surgery. He got the hint, then he kept his mouth shut. That was not the situation when we were residents. There are only one resident, maximum 2 residents. There is no other alternative. You have to do the work. You are forced to learn. The person who joined or chosen a specialty he had a passion for that subject. So the more amount of work, he used to feel more happy. He used to feel, yesterday I assisted 3 cases of perforation. Nowadays, we have to work throughout night, etc. So there is a big difference between old generation and new generation. And except few people, most of the residents have chosen surgery because they could not get into subject of their choice. That is the main reason why they don't have the passion is missing. Yes, there are few people who are really wanted to become a surgeons and they study well, they do well. And the so-called the creeps and complaints are not from this type of people. The creeps and complaints are from those people who are forced to become a surgeon. That is my concept.
మీ రెసిడెన్సీ టైంలో మీరెప్పుడు ఎక్స్‌పెక్ట్ చేయలేదా సార్?
I read long time back.
ఆ!
The person who relaxes during work is a good worker. The person who does work, that is his relaxation, not doing work and then just sitting idly. So I think that was our concept when at least I used to feel if you got
Right.
more work, you feel more happy. You are preoccupied. Your mind doesn't waver, and you know that okay, this patient has to be looked after. I still remember in Chandigarh at about 9 o'clock, a person came from Himachal Pradesh who sustained multiple injuries. He was involved in a road traffic accident. I was working in surgery, obviously. He had abdominal problem also. Abdomen was tense, tender, etc. There was a perforation, traumatic perforation. In addition, that patient had a multiple fractures. So now most of the residents have tubular vision. I hope you know what do you mean tubular vision. The person is more concerned with what he wanted to see. Say like old Arjuna's concept, but it doesn't work in medicine. The patient should have a panoramic view of the patient. Otherwise, he will not be able to sustain the pressure and complications of the patients. That person obviously is then surgery. We are interested in abdomen. Abdomen, as I told you, tense and tender, etc. But he also has multiple fractures. The orthopedic surgeon came and saw, advised some investigation. Basically, the patient required surgical intervention by the surgeon immediately because I told you the abdomen was tense and tender. So orthopedic surgeon came, advised investigation, he went back. His resident didn't come. Obviously, the responsibility lies with us because the patient requires surgery by our side because they can treat the fracture subsequently. So obviously, I don't want to boast. He miswrote few fractures because we are trained to examine the patient thoroughly. We examined not only those X-rays which were ordered by the orthopedic surgeon, and I included even other X-rays also. So when the patient was fully prepared for surgery, before we took out the patient, we asked him, "Do you want to intervene?" So he missed out one compound fracture. I still remember. So at that time, the concept was, of course, we didn't have any external fixators at that time. So we used to do the wound debridement and then fixation or at least immobilization. So he didn't come, the orthopedic resident, senior resident. He told, okay, you take up the patient for surgery. Then I told my senior resident, the patient requires wound debridement, etc. It is better you involve the orthopedic surgeon also. Then he went and told the orthopedic surgeon. Then immediately he rushed. Unlike this present generation, they should listen to the suggestions given by the juniors. That was a good idea at that time. He didn't tell, oh, I have already seen nothing, you go ahead. He didn't say anything. He just came. He came and saw. He told, yes, yes, this patient requires. So when the patient undergoes anesthesia, you do your surgery, I will do the debridement, etc. So that was the training given by our residents to the juniors. Nowadays, most of the residents have got tubular vision. They just concentrate only abdomen only. Rest of things are referred to the other specialist and that. Now you told that relaxation period. Mhm. I told you, when you work, obviously you get tired. My concept is a person cannot work more than he can do.
Yes.
The person who can relax, he may become obese and he may die of complications. But a person who really works and nobody can overwork. It's all your mental concept only. Oh, I have been overworking. There is no question of overworking. God has given 24 hours. During that 24 hours, time, each individual got capacity to work. It may vary. Some people may put in more work, some people may put in less work, but it can't go beyond 24 hours. So there is no question of relaxation during your working period. There is no question, because if work is there, you do it. So, well, if you want to get relaxed, you should not have chosen surgery or should not have become a specialist. That is my concept, even now also.
అంటే ఇప్పుడు కొన్ని ఫీల్డ్స్‌లో 36 అవర్ డ్యూటీస్, 48 అవర్ డ్యూటీస్ అని ఇట్లా కొన్ని డిపార్ట్మెంట్స్‌లో ఈవెన్ సర్జరీస్‌లో అయినా గాని ఇట్లా ఉంటది కదా సార్. అంటే అంత లాంగ్ అవర్స్ కూడా ఇంకా అలానే వర్క్ చేస్తూ ఉండగలరా?
No, I can understand your question. You are saying that if you work for a longer time, your attention will fade off,
యెస్.
you are physically fatigued, etc.
Yes.
I agree. And there is question of a committing errors also.
యెస్. యెస్.
Agreed. But my principle is, or even now also I feel, if you are working, if you are mentally tuned that you will be working for 36 hours, I don't think that fatigue will not occur. If you are tuned that I will work for only 24 hours or 12 hours or 6 hours, then after that fixed time, both physically and mentally you get fatigued. I will tell an example. When my daughter delivered a baby, I went to USA.
ఓకే.
So obviously, obviously we are not allowed to do intensive or participation with their judgment or management. I was observing them. In gynecology, I told in the beginning, my favorite subject was optics. Obviously, my daughter has to undergo cesarean section. In that particular unit, there were only 2 interns. 2 means 2, because number of MBBS seats, so-called equivalent MBBS, that MD seats, were only 50 in that particular hospital. So, in that particular department, there were only 2 residents, house surgeons, not PGs. I'm talking about house surgeons. So, I observed what are their working schedule. Both the people are available throughout from morning 7 o'clock to 2 o'clock every day. So I was wondering, and one person used to work after working hours, so-called after 2 o'clock. The person who was working or who was on duty, he comes in 7 o'clock in the morning, continues to work till next day 1 o'clock or 2 o'clock. That means he works for 36 hours. Okay. The person who was supposed to be on duty next day, he will work from 7 o'clock to 12 o'clock, and he goes room or home, wherever. He comes back at 2 o'clock. 2 means 2 o'clock only, not 2:05. Remember, there I noticed it. They may come 5 minutes early, but never late. 2 means 2. Okay. And the person who was working previous day, after his arrival, he will hand over the cases, because the 2 hours, whatever happened, he will hand over to the person. Then only he goes home. So I asked after subsequently, when I became friendly with them, so you don't feel any fatigue, etc. I said, no, no problem. I realized if you are mentally tuned that you have to work for 36 hours, you will work for 36 hours. The so-called committing errors, etc., etc., it will happen if the person is not involved himself or herself in the work. So if you say that no, if you work for more than 18 hours, you feel fatigue, etc., I don't agree. Fatigue may occur. If the person is suffering from disease or something, it can occur. But it's a rare occasion.
ఇప్పుడు ట్యూబులర్ విజన్ అట్లా అన్నారు కదా సార్. అంటే ఇప్పుడు ఇది ఎప్పటి నుంచి ఉన్న క్వెషన్ సార్ నాకు. అంటే ఒక జనరేషన్ ఆఫ్ డాక్టర్స్ ఓన్లీ విత్ ఎంబీబీఎస్. ఓన్లీ ఎంబీబీఎస్ చేసి బయట సొసైటీలోకి వచ్చి ఆల్మోస్ట్ దే కెన్ డూ అన్ని ప్రాక్టీస్. అంటే దే కెన్ ట్రీట్ మెడిసిన్, సమ్ ఆఫ్ దెమ్ కెన్ డూ సర్జరీస్. అంటే అన్ని ఆర్గాన్ సిస్టమ్స్ ఇన్వాల్వ్ అయిన అన్ని ట్రీట్మెంట్స్ వాళ్ళు ఇవ్వగలరు. అది జనరేషన్ చేంజ్ అయ్యే కొద్దీ, అంటే ఇప్పుడు వచ్చే ప్రెజెంట్ డాక్టర్స్ ఆఫ్టర్ ఎంబీబీఎస్ ఆల్మోస్ట్ దే కెన్ మెడిసిన్ బేసిక్ ప్రాక్టీస్ అన్ని కొన్ని ప్రొసీజర్స్ చేయగలరు సార్. అంటే దే కెనాట్ డూ సర్జరీస్ డైరెక్ట్‌గా, మేజర్ సర్జరీస్ కానీ ఇట్లాంటివి. సో, ఆ డిఫరెన్స్ ఎందుకొచ్చింది అంటారు సార్ మరి? అంటే ఈజ్ ఇట్ బికాస్ ఆఫ్ సబ్జెక్ట్ బాగా ఎక్స్‌టెన్సివ్‌గా ఎక్స్‌పాండ్ అవ్వటమా? లేదా ఎనీ అదర్ రీజన్? స్టడీ ప్రాపర్‌గా, అంటే ఆ షెడ్యూలింగ్ గాని, లేతే స్టడీ మోడల్ సరిగ్గా లేకపోవటం వల్ల లేదా వాట్ రీజన్? మీరేమనుకుంటారు సార్ అది రీజన్?
There are so many reasons are there. I will tell you one by one, whatever I can think of.
Yes, sir.
మీరు అన్నట్లు అప్పుడు సబ్జెక్ట్ కొద్దిగా లిమిటెడ్ సబ్జెక్ట్.
Yes, sir.
ఇప్పుడు కొద్దిగా స్కోప్ ఆఫ్ ఈ సబ్జెక్ట్ హెస్ వైడెండ్ అప్.
Yes.
అదొకటి నిజమే.
Yes.
ఇట్స్ నాట్ పాసిబుల్ ఫర్ ఎ సింగిల్ పర్సన్ టు లెర్న్ ఆల్ ద సబ్జెక్ట్స్ థరోలీ. అగ్రీ దట్ పాయింట్. పూర్వకాలంలో ఎక్స్పెక్టేషన్ ఫ్రమ్ ద పేషెంట్స్ వాజ్ ఆల్సో లెస్.
Yes.
So the person who qualified as a MBBS doctor, if he was confident, he was treating the patients beyond his capacity also.
Okay.
Now present generation is not possible because expectation of the patients and patient rules have become too much. For example, నాకు తెలిసిన ఒక డాక్టర్ గారు నా సీనియర్, హీ జస్ట్ డిడ్ MBBS. అతను యాక్చువల్గా రెఫర్డ్ క్యాండిడేట్ అని తెలుసు కదా, పాపం అనాటమీలో. అప్పుడు అనాటమీలో పాస్ రేట్ వాజ్ ఓన్లీ 40%, 50%. అతడు అనాటమీలో 2 or 3 times ఫెయిల్ అయ్యి చివరికి వెన్ ఐ వాస్ డూయింగ్ మై ఇంటర్న్షిప్, హీ వాస్ 6 months సీనియర్ టు మీ యాజ్ అ ఇంటర్న్. మీరు అనొచ్చు రెఫర్డ్ స్టూడెంట్ కాబట్టి అతనికి నాలెడ్జ్ లేదు అలా అనేసి. నో, ఎస్, హీ ఫెయిల్ ఇన్ అనాటమీ, అగ్రీడ్. అండ్ ఆయన కెపాసిటీతో ఏదో పాస్ అయ్యాడు, మెడిసిన్ పాస్ అయిపోయాడు. నాకంటే ఆయన హీ వాజ్ ఆల్మోస్ట్ 6 years సీనియర్ టు మీ ఇన్ ఏజ్. I was one of the youngest chaps in my batch, but he was 6 years in it. He already got married at that time. He already got one child. He was such a nice person. Even though he was senior, colleague, internship లో నా కొలీగ్. సంపత్, నీకు సర్జరీ అంటే ఇష్టం అని చెప్పావు కదా, నువ్వు సర్జరీలో నా జాబ్ చెయ్యి, నీకు వేరే విధంగా నేను కంపన్సేట్ చేస్తాను అని చెప్పాడు. నేను ఎందుకు ఇలా అడుగుతున్నాడు? ఐ వాజ్ హ్యాపీ. ఓకే, ఐ కెన్ డూ ది సర్జరీ. హీ అలో మీ టు అసిస్ట్ ఎక్సెట్రా. He told me, and practice ఉండేది because I told he already got married, he got one child. So even before he became intern, he was practicing. ఎలా ప్రాక్టీస్ చేస్తున్నారో నేను అడగచ్చు. నో MBBS degree, but in his village, he used to go from Kannur to a small village and he put up a boat and he used to teach. And there was no complaint against him, at least. అది తర్వాత ఇంటర్న్షిప్ అయిపోయిన తర్వాత he didn't want to become a specialist because of he realized his capacity, etc. Now, after 6 or 7 years, I came across him. He was a successful practitioner. అడిగాను, ఏమేమి చేస్తున్నారు సార్ అని అడిగాను. అన్ని కేసులు చేస్తున్నాను సంపత్ అన్నాడు. అంటే సర్జరీ కూడా చేస్తుంటే అవును అన్నాడు. ఏం సర్జరీ చేస్తారంటే చెప్పారు. బిలీవ్ ఇట్ ఆర్ నాట్, హీ వాస్ డూయింగ్ అపెండిసెక్టమీస్, హీ వాస్ డూయింగ్ క్లోజర్ ద పర్ఫరేషన్, హీ వాస్ డూయింగ్ హిస్టెక్టమీస్, DNC in gynecology, and then he was doing intestinal obstruction, release of adhesions. ఏం ప్రాబ్లం ఏం రాలేదా సార్ అంటే ఏం రాలేదన్నాడు. పేషెంట్స్ బికాస్ న్యూ జనరేషన్ అడిగాను, పేషెంట్స్ ఏం ప్రాబ్లం వాళ్ళకి ముందే చెప్తాను నేను, ఇలా ఉంది చేయమంటే చేస్తాను, లేదంటే తీసుకెళ్ళంటాను. ఒక 70-80% పీపుల్ దే విల్ యాక్సెప్ట్, ఎందుకంటే నా పాస్ట్ రికార్డును చూసేసి. ఏదో 20% మేము వెళ్ళిపోతాం సార్ అంటారు, వెళ్ళమని చెప్తాను. ఆ సిచ్యువేషన్ ఈ 2025లో వీలవుతుందా? వీలవదు. ఎందుకు కాదు? సో మెనీ రీజన్స్ ఆర్ దేర్. ద పర్సన్ హూ ప్రాక్టీసెస్ విత్ MBBS degree, he doesn't have much knowledge. ఫస్ట్ పాయింట్. ఎందుకు లేదు అంటే దానికి ఎన్నో కారణాలు ఉన్నాయి. మేము మెడికల్ కాలేజీలో చేరినప్పుడు మా MBBS ఇంటేక్ స్ట్రెంత్ 120, ఇప్పుడు 250. బికాస్ ఆఫ్ కార్పొరేట్ సెక్టర్, బికాస్ ఆఫ్ సో మెనీ హాస్పిటల్స్, సో మెనీ డాక్టర్స్ అవైలబుల్, పేషెంట్స్ గవర్నమెంట్ హాస్పిటల్కి వచ్చేది చాలా తక్కువ అయిపోయింది ఇప్పుడు. ఇంకా ప్రైవేట్ కాలేజీలో అయితే చెప్పక్కర్లేదు. PG సీట్స్ నాట్ లెస్ దాన్ 12, నెంబర్ ఆఫ్ పేషెంట్స్ ఆర్ లెస్ దాన్ 12. అలా ఉంది. కాబట్టి హౌ కెన్ వి ఎక్స్పెక్ట్ గుడ్ అవుట్పుట్ ఫ్రమ్ ద మెడికల్ కాలేజ్? వి కాంట్ ఎక్స్పెక్ట్. కాబట్టి అదొక ప్రాబ్లం. ఇప్పుడు సర్జరీ అయిన తర్వాత వాళ్ళకు మెడిసిన్ నాలెడ్జ్ చాలా తక్కువ. దే డు నాట్ నో. దే certain people, they know how to do the basic surgical skill, they will get and they do the surgery. చిన్న కాంప్లికేషన్ వస్తే, ఎలక్ట్రైట్ ఇంబ్యాలెన్స్ వస్తే, దే డు నాట్ నో హౌ టు మేనేజ్. పూర్వకాలంలో అలా ఉండేది కాదు. దే వర్ ఏబుల్ టు మేనేజ్. అది ఎందుకు అంటే దేర్ ఇంట్రెస్ట్ అండ్ నెంబర్ ఆఫ్ పేషెంట్స్ దే ఆర్ సేయింగ్ ఆర్ మచ్ మోర్. ఇప్పుడు చాలా తక్కువ. డ్యూరింగ్ ఇంటర్న్షిప్ ఇట్ సెల్ఫ్ ఐ వాజ్ అలౌడ్ టు డూ హెర్నియా, appendectomy, hydrocele, many. All short cases, so-called short cases, sudden sebaceous, lipoma, etc. Is it possible for first year resident to do all these things now?
No.
Not possible. కాబట్టి పూర్వకాలానికి ఈ కాలానికి ఇంత డిఫరెన్స్ ఉంది. పూర్వకాలంలో ఫస్ట్ సర్జరీ, నేను న్యూరో సర్జరీ అని చెప్పాను కదా, నా ఇంటర్న్షిప్లో
అవును.
సర్జరీ, జనరల్ సర్జరీ ఐ వాజ్ ఇన్ యూనిట్ 2. ఫస్ట్ ఓపీడీ sebaceous ఓవర్ ద ఆర్మ్.
అవును.
మా రెసిడెంట్ చెప్పాడు, సో పీజీ స్టూడెంట్, వెళ్ళు నేను వచ్చి వస్తాను, నేను హెల్ప్ చేస్తానని చెప్పాడు. బికాజ్ ఆఫ్ సమ్మర్ హీ కుడ్ నాట్ కమ్. అక్కడ మైనర్ రోడ్కి తీసుకెళ్ళాము, నేను ఇంకో మా కొలీగ్. అప్పుడు చెప్పాను కదా, నెంబర్ ఆఫ్ స్టూడెంట్స్ ఆర్ లెస్. ఇంటర్న్స్ ఆర్ ఓన్లీ 3 ఇంటర్న్స్ మా బ్యాచ్లో. వెళ్ళిన తర్వాత కర్నూలు మెడికల్ కాలేజ్ కథ చెప్తున్నాను. మైనర్ ఒకటి స్టేర్ కేస్ కింద ఉండేది, ఎమర్జెన్సీ థియేటర్ బయట. అక్కడికి వెళ్ళిన తర్వాత లోకల్ అనెస్థీషియా ఇచ్చాము, ఇన్సిషన్ ఇచ్చాను, చేస్తున్నాను. పేషెంట్ దగ్గర నుంచి రెస్పాన్స్ లేదు, శబ్దం రాను, ఇవాళ స్నోరింగ్. నేను భయపడిపోయాను, పేషెంట్ ఏమైపోయాడు అనేసి. ఓఆర్ఏ అంట కదా, ఆపరేటింగ్ రూమ్ అసిస్టెంట్, ఏం పర్లేదు సార్, నిద్రపోతున్నాడు సార్, ఏమి పర్లేదు, చేసేసాను అన్నాడు. ఐ టుక్ మోస్ట్ ప్రాబబ్లీ మోర్ దెన్ హాఫ్ అన్ అవర్ టు రిమూవ్ సచ్ ఎ హ్యూజ్ సెబేస్ సిస్ట్. ఇప్పుడు ఇంటర్న్ సెబేస్ సిస్ట్ చేయాలంటే హీ విల్ just work up. He will never do. Even if you are the resident ask him to do, that is rare, because the residents themselves have not done enough basis to give other case to the others. ఒకవేళ అలా జరిగితే కూడా హౌస్ విల్ నెవర్ వాలంటీ టు డూ దిస్ సర్జరీ. కాబట్టి ఒక రీజన్ కాదు, ఒకటి నెంబర్ ఆఫ్ పేషెంట్స్ ఆర్ లెస్, నెంబర్ ఆఫ్ డాక్టర్స్ ఆర్ మోర్, ట్రైనింగ్ is diluted, lack of confidence. So there are so many factors. We can't blame only one person. The system slowly got deteriorated.
మీ అప్పటికి ఇప్పటికి డిఫరెన్స్ ఎలా ఉంది సార్? అంటే ఓపెన్ నుంచి లాప్రోస్కోపీ నుంచి ఇప్పుడు రోబోటిక్. సో ఈ వేరియేషన్స్ అన్నిటిని మీరు ఎట్లా అడాప్ట్ చేసుకున్నారు?
There are certain advantages in the present era. First thing I should say that imaging modalities have come very handy to the surgeon. Unimaginable. మాతో కంపేర్, మేము ట్రైనింగ్ అయినప్పటికీ ఇప్పటికీ అది ఫస్ట్ పాయింట్. సెకండ్ కాన్స్ ఐ రియలైజ్ ఇంప్రూవ్మెంట్ అండ్ అనస్థీషియా, both techniques and availability of the equipment. These two are main important thing where there is a drastic improvement has taken place in the surgery. Main. We didn't have an ultrasound, leave alone CT scan, MRI, etc. etc. We didn't have an ultrasound. నేను ఇంటర్న్షిప్ చేసేప్పుడు gallbladder surgery, of course, in South India, since we didn't have an ultrasound, the number of gallbladder surgeries were less. Stones ఉండేటివి కానీ డిటెక్షన్ తక్కువ, బికాజ్ అల్ట్రాసౌండ్ లేదు కాబట్టి. ద పర్సన్ హూ ఈస్ సఫరింగ్ ఫ్రమ్ డిస్పెప్సియా, సో కాల్డ్ gallbladder dyspepsia, కొలిలిథియాసిస్, ఏం టెస్ట్ చేసేవాళ్ళని తెలుసా? ఫ్యాటీ మీల్ ఇచ్చి ఎక్స్రే ముందు తీసి మళ్ళీ ఫ్యాటీ మీల్ ఇచ్చిన తర్వాత మళ్ళీ ముందు టెలిపేక్ టాబ్లెట్ ఇచ్చేవాళ్ళం ముందు రోజు నైట్. ఆ పేషెంట్కి ఇచ్చిన తర్వాత వీ షుడ్ సీ దట్ పేషెంట్ డజంట్ వామిట్ అయితే మళ్ళీ ఇంకో 6 టాబ్లెట్స్ ఇచ్చేవాళ్ళం. మరుసటి ఎర్లీ మార్నింగ్ 8 o'clock ఓటీ స్టార్ట్ అవుతుందంటే 6:30కి వచ్చి ఓటీ ఎక్స్రే డిపార్ట్మెంట్కి వెళ్ళి ఎక్స్రే తీసేవాళ్ళం. తీసిన తర్వాత అప్పుడు ఫ్యాటీ మీల్ అంటే ఏముండేది, వెన్న, పెరుగు, గడ్డ పెరుగు, దాంతో అన్నం కలిపి తినమని చెప్పేవాళ్ళం. తినమని చెప్పి మళ్ళీ ఎక్స్రే తీసేవాళ్ళం. ఒకవేళ ఆ టెలిపాక్ టాబ్లెట్ కాన్సన్ట్రేట్ అయ్యి ఈ ఫ్యాటీ మీల్ అయిన తర్వాత పూర్తిగా అవ్వకపోతే, ఎంటీ కాకపోతే అప్పుడు అనుకునేవాళ్ళం, ఓహో ఇతరికి గాల్ స్టోన్స్ ఉన్నాయనేసి. తర్వాత యూనిట్కి వెళ్ళి చీఫ్ చెప్తే ఎస్ సార్ ఇట్స్ పాజిటివ్ అని చెప్తే సరే ఆ పేషెంట్ మళ్ళీ ప్రిపేర్ చేసేవాళ్ళు. ఇప్పుడు just do the ultrasound. Even the person comes with big pain abdomen, even without putting your hand over the abdomen, you order for ultrasound. Most of the time, patient himself come with a ultrasound report to the surgical OPD. Sir, గాల్ బ్లాడర్లో స్టోన్స్ ఉన్నాయని చెప్పినారు సార్ డాక్టర్ గారు అని అన్నారు. ఇమేజింగ్ టెక్నిక్స్ have become available at fingertips. Main difference. Second thing is, I told you, anesthesia technique. During my intern days, during my first year, of course, in Chandigarh is not a problem, but in AFMCL there was no problem. But there are certain colleges where hospitals where anesthetists refused to do the surgery, the patient's condition was very poor. I'm not exaggerating. It happened. And I heard stories, and even I also did when I was an intern. The person who came with the perforation, peritonitis, general condition was very poor. We used to give local anesthesia. We used to keep a drain in the flanks and hope for the best. I remember about 4 or 5 cases we must have done during our internship. Out of that, 3 people succumbed. 2 people managed to survive. Most of the perforation must have been very trivial. It must have got sealed off. But mortality rate was very high. Now, very rarely we see, I'm talking about a good anesthetist, say that patient is unfit for surgery. Most of the time, if the anesthetist is not inclined to give anesthesia, he may ask for more investigations. That's all. But he will never accept that he can't give anesthesia because of the improvement in the anesthesia technique. And of course, availability of the equipment and medicines. Wonderful medicines are available. And then we used to ask during our internship, what is your caste? Because because Vaishya patients, they used to have a deficiency there. So successfully they used to avoid, etc. Nowadays, I don't think anybody knows about it also. Even the person has got successful reaction, cholinesterase deficiency is there. The anesthetist will accept it. Okay, no problem, we got all 4 drugs are there, we'll do the surgery. But very rarely I see present day good anesthetists refusing give anesthesia for a surgery. So these 2 things are. Now you told about so-called availability laparoscopic and robotic techniques, etc. At the time, because of lack of equipment, etc., we are only there doing only open surgeries. You asked specifically, how did you manage to become a the laparoscopy? In the year 2004 or 2003, I went to Delhi to undergo laparoscopic training. And most of the hospitals where I worked were not equipped with the laparoscopic equipment. When I left service in Air Force in 2006, I came to Kadapa, RIMS, Rajiv Gandhi Institute of Medical Science, where we had a laparoscopy. So by the time I joined, my assistant, not my senior, he was already trained in laparoscopic surgery. So I assisted him for about 3 months. Whatever I had training in Delhi, plus training under him, though he was my junior, gave me some confidence to the laparoscopic surgery. Then I was doing laparoscopic surgery. Then after certain years, I realized that when I came to Narayana Medical College in the first year, I did laparoscopic surgery. Then the number of patients are less, availability equipment was not suitable. There are so many other issues were there. Then the assistants who were in my unit, they were able to do better surgery than me because of their young, they learned laparoscopy surgery at a younger age. Obviously, their dexterity is much more than me. And then I stopped doing it. Regarding robotic, I don't have any experience, so I can't tell. But present day generation, I'm give you advice. The person who want to become a good surgeon, he should be well versed with the laparoscopy. I don't say that everybody should be well versed with robotics because it's still confined to only few centers. And that's that interest, passion, opportunity is there to learn robotic surgery, you do it. I don't deny it. But if you want to call yourself a good surgeon, I'm talking about present generation, he should have a good laparoscopic technique also. There is no doubt about it. Regarding the laparoscopy not able to the open surgeries, it depends upon the individual. The person who is not able to the laparoscopic surgery should be able to do the case by open method. If the person is not equipped or trained enough to become open surgery, he should not have done laparoscopic surgery. That is the main concept.
Back to residents, our residents are undergraduate also. సో ఇప్పుడు ఒక బ్రాంచ్ అంటే ఎంబీబీఎస్ అయిపోయిన తర్వాత ఒక బ్రాంచ్ చూస్ చేసుకునే ముందు ఏ ఆస్పెక్ట్స్ మైండ్లో ఉంటాయి సార్?
It's very difficult to answer. I will tell you the reason. In my view, if a person becomes a doctor, I'm talking about a basic doctor with MBBS degree, he should be able to choose a specialty based on his interest. That is first principle.
Yes.
Now, the problem with present generation is that is not the only criteria for the resident to choose a specialty. There are so many other reasons. One is lack of opportunity. The person who wants to become a surgeon, he can't get into surgery. That is one aspect. Second thing is marketing compulsions. He's not worried about present. He's worried about his future, whether he can get enough money or not, whether he's able to survive or not. The problem with most of the present day generations is they are impatient. Most of the residents are impatient. A person who, for example, I will tell my own residents, the person who finished their MS, within 1 year, they would like to have a house or car, not basic model car, but wanted a bigger car or expensive car. I will not use the word bigger car, expensive car. During my internship, the person who used to come in a car, only unit heads were coming. Only one assistant professor had a car because of his own richness, because of the ancestral property. Most of them, 90%, used to come on a scooter, and one neurosurgeon used to come on a bicycle. They never aspired to become a overnight rich man. Gradually, they acquired wealth, but not in a shorter time. Is it possible for the present generation? No. The first thing he would like to do is, after getting a degree, would like to have a car, and he's never happy with that car. He's thinking about, if he buys his basic model, he will think about expensive model. So marketing compulsions are more. Third thing is, I will give you an example. In about 20 years back or 15 years back, most of the PGs, their first choice was radiology, thinking that less work, sitting in an air-conditioned room, do their X-ray reading or CT scan reading, or in some segments, MRI reading, if the facilities are available. And they can use to make a lot of money. So that was main idea to choose a radiology. Now in 2025, I am sure all the radiologists are not employed properly. Only certain people are still got good opportunity. They are able to make enough money or more than required money. On the top of it, you use the word artificial intelligence. The problem with the artificial intelligence is a double-edged weapon. The person who got enough knowledge, sitting at home, he can get the X-rays and CT scan films from different sources, and he can read. At the same time, the person who wants to do the specialization in radiology is not able to get that. So it's a double-edged weapon. So it will help. So choosing specialty is first criteria, the passion. If the person this passion is clouded by marketing and peer competition, etc., I don't want to comment. Okay. So one principle is there. You may be interested in surgery or a medicine or some whatever subject, because the reason you are not able to do it in the particular chosen specialty, but you are thrust upon with some other subject. If you are genuinely good, I use the word genuinely good, you can still excel in it. Even if you want to become, if you can't get into specialty of your choice, even if you choose some other specialty, if you are genuinely good, if you put in more effort and you can excel it, and I'm sure you will get recognition. So passion is the most important thing. Sometimes passion is not able to, what do you call, commensurate with the achievement. That is a different issue. But even then, you can always circumvent the problem and then get interest into that particular subject and then become a specialist of your chosen, if not chosen, trust subject.
అంటే ఇప్పుడు వేరే కండిషన్స్ కూడా ఎఫెక్ట్ చేస్తాయి కదా సార్. అంటే ఇప్పుడు సర్జరీ బ్రాంచ్ చూజ్ చేసుకున్నాను అనుకోండి సార్. నెక్స్ట్ సూపర్ స్పెషాలిటీ చేయాలి. సూపర్ స్పెషాలిటీ చేసిన తర్వాత టు గెయిన్ కాన్ఫిడెన్స్ అంటే ఒక ఇండివిడ్యుయల్‌గా వెళ్లి ఆపరేట్ చేయడానికి కొంత ఎక్స్‌పీరియన్స్ అంటే ఒక చోట వర్క్ చేయటం అట్లా ఆహ్, ఎక్స్‌పీరియన్స్ గెయిన్ చేయాలి. అంటే ఇంకొన్ని బ్రాంచెస్ ఫర్ సపోజ్ కార్డియోవాస్కులర్ సర్జరీ ఇవి తీసుకోవడానికి ఎక్స్‌పీరియన్స్ గెయిన్ చేయడానికి కొంచెం టైం పడుతుంది. అట్‌లీస్ట్ అంటే రీసెంట్‌గా ఒక సిటీవీఎస్ కాన్ఫరెన్స్ లేదా సిటీవీఎస్ డాక్టర్‌తో వాళ్ళతో మాట్లాడితే ఇట్ టేక్స్ అట్‌లీస్ట్ ఒక 40 ఇయర్స్ వరకు నీకు ఎవరో ఒకళ్ళు సపోర్ట్ చేయాలి. అప్పుడే నువ్వు అప్పటి నుంచి నీ ఎర్నింగ్ గాని, నీ కెరియర్ గాని స్టార్ట్ అవుతది. ఇట్లా ఈ కైండ్ ఆఫ్ అంటే సజెషన్స్ ఇట్లా ఇస్తున్నారు సార్. అప్పుడు ఆ రిమైనింగ్ యాస్పెక్ట్స్ కూడా మనం కన్సిడర్ చేయాలి కదా సార్. నాట్ ఓన్లీ అబౌట్ ప్యాషన్ బట్ రిమైనింగ్ అదర్స్. ఆల్సో కొంతమందికి ఫ్యామిలీ కండిషన్ సపోర్ట్ చేయలేకపోవచ్చు. ఎక్స్‌పీరియన్స్ అంతా గెయిన్ చేసే టైం అంతా దీనికి. సో, వ వ అట్లాంటి వాళ్ళకి ఏం సజెషన్ ఇస్తారు సార్?
First thing I told you should have a good passion. Okay. Okay, you are becoming, for example, you wanted to talk about choosing of a super specialty.
Yes.
If you become a basic surgeon with a good basic surgical skills, you should be able to excel in any specialty. That is my point. You should have basic anatomy knowledge and you should be well equipped with the basic surgical skills. If these two things are there adequately, a person can become a super specialist in any subject. That is my, yes. There are other factors, like you mentioned cardiothoracic surgery and even neurosurgery also to some extent. Unless you get a good backup, you can't practice these two subjects mainly. Plastic surgery, you can practice. Gastrectomy surgery, if you get a good general surgery skills, you should be able to manage it. Urology, if you're trained, I'm talking about a degree. If you're trained enough, you should be able to practice it. But these two major specialty, cardiothoracic, since you mentioned it, and of course, neurosurgery, you should have a good backup should be there. You can't do independently. Okay. Yes. Rarely you may be able to do it, but there are exceptions. They are not a routine. Though you mentioned 40 years, I don't agree with it, but it will take longer time. Agreed. I will give an example also. Subsequently, I will tell. If you want to choose cardiothoracic surgery, you have enough financial support should be there if you want to excel in it on your own. Or you start doing, gain experience, then branch out, choose your own nursing home or a hospital to develop on it. It's not possible in all. Okay. So then element of luck is also there. My wife underwent CAPG in Hyderabad. The anesthesia was extremely nice. And on the day of surgery is over. Evening, the anesthetist himself gave a ring. Sir, మీరు చూడాలంటే మీరు వచ్చి 5 o'clock రండి, నేను ఇక్కడే ఉంటాను, I will take you into the ICU, etc. etc. And he was very nice person. Srinivasu, I remember his name also. And then my wife was there for about 4 days in the hospital. So during those 4 days, little bit of more interaction with him. So during conversations, he told me, on his own, I didn't ask. He was referring to one surgeon. He showed me, sir, చూడండి ఆ డాక్టర్ గారిని అనేసి. I will tell you about him అని. తర్వాత ఆయన చెప్పాడు, as anesthetist he knows all the techniques practiced with the various surgeons. I think you should accept it because he has seen the surgeons under stress. Yes. Obviously, when you're doing surgery, some complication can occur and how he reacts, how he overcomes it. Obviously, you should accept his judgment. That's my opinion. As anesthetist, he is independent. He's not comparing one or he's just observing them and he formed his own opinion. అతను చెప్పిన ప్రకారము, the person whom I referred, Mr. Rao, he is more experienced and got more confidence in doing surgery. But he didn't get enough recognition. I told you, the surgeon under stress, suppose you are doing surgery, you encounter some problem, unexpected problem. Expected problem are great. Most of the people are able to tackle it. Unexpected problem can also come up. How the person tackles, I think that gives a better idea about his experience and confidence, at least to the anesthetist. because the anesthetist is also responsible, is not for
Yes.
the patient's outcome. So he is more confident if the suppose unexpected problem arose and the surgeon who is doing it, is suppose Mr. Rao is there, the anesthetist is relaxed, no problem. He should be able to tackle it. So for that, it can happen with the neurosurgery also. So it is a bit difficult. I can't say that 40 years will not be, not necessary. Maybe within 5 to 10 years, the person should have enough confidence.
Oh.
It all depends upon how he has been trained. A person who does MS, MCH in a good center. Good center means you know about how a person assists the situation in a hospital about obstetrics, the number of deliveries conducted in a month.
Yes.
That gives a rough idea. He did not see anything. He just assessed how many deliveries are conducted in a month's time, particular department. That gives an idea about working condition of that hospital. I'm talking about gynecology, obstetric department.
Yes.
Same thing. You may get degree in a hospital where they do only 2 or 3 cases in a week's time.
Yes.
Obviously, he doesn't have enough experience. The person who works in a hospital where the more number of cases are there, obviously he is exposed to more number of patients, and he got more experience by the time he finishes MCH. So it depends upon so many factors. You can't just say that it will take longer time to establish himself or herself to become a good. Yes, I already used the word. A bit of luck element is also there. Not all people become a good, get a recognition. I can give innumerable examples. I will tell my own experience. My second brother, who is better than me in all aspects, he didn't become a doctor.
Yeah.
It doesn't mean that I am great. I rate him is better than me because of so many factors.
Yes.
So maybe because God made me to become a doctor, so I became a doctor. It doesn't mean that the person who is not a doctor is inferior to me. It's not like that.
ఈ సాచురేషన్ సార్ ఇప్పుడు ఎక్కడ ఏ పేరెంట్ తీసుకున్నా ఈ బ్రాంచ్ సాచురేట్ అయిపోయింది. ఇక్కడ ఎంతమంది డాక్టర్లు ఉన్నారు, అసలు ఎంతమంది డాక్టర్స్ అయిపోయారు, అందరూ ఎంబీబీఎస్ చేస్తున్నారు, ల్యాక్స్ అండ్ ల్యాక్స్ ఆఫ్ సీట్స్ ఉన్నాయి, ఇప్పుడు ఇంకా ఇంక్రీజ్ చేస్తున్నారు. సో ఈ కండిషన్లో సర్వైవల్ ఎట్లా ఉంటుంది సార్? ప్రజెంట్ యంగ్ మైండ్స్లో ఉన్నది అది. సో ఆల్మోస్ట్ టైప్ 3 టౌన్స్కి వెళ్ళినా కానీ సూపర్ స్పెషాలిటీ డాక్టర్స్ ఉంటున్నారు. ఈ డాక్టర్స్ ఇంతమంది ఉండరు, మనం వెళ్ళి మళ్ళీ కొత్తగా ఎలా సర్వైవ్ అవ్వగలం అనేది చాలా మందికి ఒక కైండ్ ఆఫ్ ఫియర్ ఉంది సార్. అది ఎట్లా ట్యాకిల్ చేసుకోవాలి?
It's very simple. I just few minutes back only told you. If you are good, you are good. That's all. Okay. Whether you got number of particular specialties or more, it makes no difference at all. If you are good, genuinely good,
Yes.
you should be able to survive it. That is a simple principle. Regarding number of medical graduates, number of specialists, number of super specialists availability as and now, earlier the market demanded it.
Right.
Market demanded means the number of specialists, medical professionals are less. So the government has taken a policy of increasing all the number of seats, both in basic, undergraduation, post-graduation, super specialty. That has become too much because of the mushrooming of the private hospitals. Now, of course, there is a certain amount of restriction is there, but earlier there was no restriction. The number of seats available is much more. Now, because NMC, though they are liberalizing it, and most of the private medical colleges are taking advantage of it. Recently, I'm talking about good 1 week back, my own PG who is doing senior residence in Anantapur, that girl told me, sir, we got a neurosurgery in our hospital. That hospital is existing for last more than 25 years. And the specialties are started maybe about 10 years back or 8 years back. I'm talking about MD, MS,
Yes,
etc.
broad specialty.
Broad specialty. And within no time, government has become maybe kind enough to do super specialty without realizing whether there is enough trained manpower is available, whether trained adequate clinical materials available, they sanctioned it. And one of the residents got a seat in it. He just wanted to become a neurosurgeon, so he joined there because he got a seat. At the end of the 3 years, I'm sure he lacks confidence because he has not done enough surgeries, whether he has not done enough, seen any number of good patients. And obviously, we can't expect him to do miracles once he comes out with a degree. Acquiring a degree is not difficult nowadays. Okay,
Yes.
once you get MS, MCH, you are labeled as a neurosurgeon. Whether you are confident enough to do the practice, that is $1 million question. Obviously, the person wanted to become and he wanted to get a degree. Suppose if it's genuinely good, you should have chosen a college in a better institute where number of cases are more. So that is a wrong concept on the person himself. And he said that I have to go and work in a smaller town to practice it. I pity the patients in that. I suppose the patient chooses the specialist. I remember when I went to Australia on a WHO fellowship. So I was working in a traumatology unit.
Yes.
So the so-called residents. So I was just asking them which specialty you want to choose, etc. You are interested in traumatology or you want interested in gastroenterology, something like that. In Australia, there is a very simple procedure is there. I think government has taken decision. At the end of every year, academic year, they will assess the number of seats required for the entire country, number of seats in particular specialty. And accordingly only they will advertise. The resident who was working in my unit is working as a general surgeon, and working in a traumatology. It's come on a rotation. And do you know what did he tell me? Sir, by the time, not sir, because they don't, sir, doctor, it's not like that. By the end of my so-called training, rotation, I know the number of vacancies in general surgery will be less. The number of specialists required in ENT is more. So I got better chance to get into ENT rather than surgery. So most probably, because of his own compulsions, I want to become a surgeon. Whether it's ENT, ophthalmology, or general surgery, or gynecology, medicine, or reference, I want to become a surgeon. I want to do the so-called surgical drug. So I decided to choose ENT specialty as his major specialty. Afterwards, he may branch out to cosmetic surgery, rhinoplasty, all those things are different. So that is one aspect. The government decides number of specialists. Accordingly, you can mold your aspirations. I'm talking to mold means the students can mold. Okay, I'm unlikely to get a general surgery, or I'm likely to become a neurosurgery, so I'll become a surgeon. That is one aspect. If you're general, in India, it's not like that. So number of specialists are more, number of PGCs are more. If you don't get into a particular specialty, if you're desperate, you will join some other specialty. And I told you in the beginning, if you're genuinely good, you remain good. Whether you choose your sports specialty or compulsions made you to choose specialty or marketing decides your specialty. If you are genuinely good, you remain good. I do not know whether you remember my daughter from Folsom. I used to tell when my children were growing up, whatever you do passionately. If you want to be, she used the word janitor. Janitor word was not there when I was talking to them. I'm just told sweepress, cobbler. Yeah. So if you want to become a good, in Kadapa, I still remember, I used to go to one cobbler because that man is really good. If that man is not available, I will postpone. Yeah. So if you are genuinely good, you remain good. So number of specialists more, competition is more. Yes, these are superfluous. If you are genuinely good, you earn enough money, you earn enough recognition. Whether you go to bigger hospital, whether you go to a smaller hospital, it makes no difference. If you are genuinely good, you are good. I'll give you examples. Rela, you must have heard, the famous liver surgeon. In Chennai is there. He did MBBS from, I think, Madurai Medical College at Tanjore. Then he did a MS from Madras Medical College. It was good. Then he went to London. He did a FRCS and he got a so-called training in a liver unit, liver transplantation. Luck favored him. and then because of circumstances, he has to do one fetal surgery, neonatal surgery.
Okay.
The liver transplantation was forced upon him. Fortunately, the patient survived. That gave him recognition, confidence. And then he was working there in that particular hospital, but because of some family reasons, he used to come to India once in 3 months or 6 months. And then he started doing surgeries here. Everything, he had a good hand, basic surgical skill is there, plus marketing capacity was also there. He established himself in one of the good transplant surgeons in India now. Is it possible for everybody?
No.
It's not possible. But competition is there. Yes, competition is there. But still he survived because you may say bit of element of luck, but I'm sure luck must have been there. But I always see that the person who is successful is confident also. Only those people survive, not all people. So number two, number three tier, or the fourth tier, super specialist availability, it can bound happen. Number of specialists, where will they survive? They have to go. So if you are good, even if you are sitting in Hyderabad, you will do well. Whether you are sitting in a small place like Rajanpeta, you will do well.